Good afternoon, everyone. So, my name's Jake, and over the next little while here, we'll be exploring the topic that I chose for today, which is pregnancy induced cardiomyopathies. And specifically related to that, we'll be talking about peripartum cardiomyopathies. So, the discussion today that we're going to be kind of diving into is things like what are peripartum cardiomyopathies defined by, the physiological and anatomical changes that occur, um, and some more deeper topics that kind of relate to the field of paramedicine. So, kind of before we get into things here, we're going to take a look at what are some of the learning outcomes that we have for today in our discussion together. So, as mentioned, today's topic specifically focuses on peripartum cardiomyopathies as it relates to pregnancy-induced cardiomyopathies. So, when we're talking about the learning outcomes that we kind of want to achieve through this presentation, we're going to start off with a brief overview of what are cardiomyopathies defined as. So that's just generally, that's including all cardiomyopathies. We're going to talk about some various types of them and just some brief facts about each individual one. We're going to be discussing and looking into what are the normal anatomical and physiological changes that occur during a normal pregnancy. We'll also be talking about what is peripartum cardiomyopathy defined as and what are the anatomical and physiological changes that occur. We'll be discussing what are clinical presentations of peripartum cardiomyopathies and how they relate to the field of paramedicine. Further, we'll be discussing the treatment for it and how it affects our pre-hospital care. And then lastly, we want to kind of achieve what are the genetic risks and outcomes for women with peripartum cardiomyopathies. So when actually discussing and defining the all-encompassing cardiomyopathy definition, it can be solely broken down to and defined as a disorder of the myocardium in which both structural and functional damage are present. So when a healthcare clinician or a healthcare practitioner is going to actually diagnose an individual with a cardiomyopathy, any additional cardiac comorbidities, this including coronary artery disease, hypertension, valvular disease, and any congenital heart defects, all these things have to be absent in the presence of a diagnosis. So when diving deeper into some various types of cardiomyopathies, we can look at sort of the most common ones that we tend to see out in the field. And those are going to include hypertrophic cardiomyopathy, which is typically manifested as septal hypertrophy leading to left ventricular outflow obstruction. We can also see things like dilated cardiomyopathies, which is defined by the presence of left ventricular dilation and contractile dysfunction. And kind of relating to that, dilated cardiomyopathies are one of the most common causes of heart failure and are the most common reason for heart transplant. Additionally, we can see things like arrhythmogenic right ventricular cardiomyopathy, which is defined by the progressive loss of muscle tissue in the right ventricle that eventually is replaced by this fibrofatty tissue. There's some more or some different cardiomyopathies that we can discuss, such as Takotsubo, which is more of like a stress-related cardiomyopathy. We also have another less common one, which is left ventricular non-compaction, as well as the one we're discussing today, which is peripartum cardiomyopathies. So here's an image or kind of a comic here that I think does a really good job of kind of laying things out as it pertains to the various types of cardiomyopathies that we just discussed in the last slide. So on the left here, we have your hypertrophic cardiomyopathy, which really relates to the diastolic dysfunction. We can see that there's a high risk of sudden death in young athletes. I think it's the second leading cause of death in young athletes, and that the specific etiology surrounding it is that there's this thickened left ventricular wall, which then leads to that obstruction like we discussed. In the middle here, we can see that we have the most common type of cardiomyopathy, which is our dilated cardiomyopathy. And that pertains to a decrease in systolic dysfunction, as well as in terms of anatomical structural changes, we have an enlargement of all cardiac chambers. And then on the right here, we have our restrictive or our arrhythmogenic right ventricular, which discusses or looks into the deterioration of the right ventricular wall and is going to affect the diastolic dysfunction. And as it states in that little comic there, it's definitely not as common as your hypertrophic and dilated. So now kind of moving on from the various types of cardiomyopathies and kind of moving into more the pregnancy side of things. So before we can kind of dive into peripartum cardiomyopathies, we want to take a look at what are some of the normal changes that occur throughout or amid a normal pregnancy. And so amid a routine pregnancy, cardiac output is going to be increased through two important physiological modifications. And so when we talk about cardiac output, those two things that make up cardiac output are going to be your heart rate and your stroke volume. So the first thing that's going to occur is there's going to be this increase in stroke volume, and that's going to occur in your first and second trimesters. And then additionally to that, you're going to have an increase in heart rate, which is going to occur in your last trimester. Those two changes are then going to overall increase your cardiac output by roughly 30 to 50%. And so this structural change and this physiological change that takes place maternally is going to ensure that both the maternal and fetal circulation are receiving adequate oxygenation and nutrients so that the body can kind of fight off any complications that may occur. So when continuing to discuss these anatomical and physiological changes that occur in a normal pregnancy, we're also going to see this spike in plasma volume. And as we know, the blood is made up of kind of four constituents. You got your red blood cells, your plasma, your white blood cells, and your platelets. But specifically speaking to your plasma and your red blood cells, as the body kind of adapts to these changes that are occurring through pregnancy, you're going to have this increase or this rise in blood plasma, which is then going to increase beyond the levels of the red blood cell count, which then eventually causes what's considered dilutional anemia. Additionally to that, there's also this drop in systemic vascular resistance by about 35 to 40%. And then this leads to a decrease in blood pressure by about 10 to 15 millimeters of mercury, specifically in the systolic blood pressure. So all this is taking place in your second trimester, and then leading into your third trimester, all these values are going to return kind of back to baseline again, and the pregnancy will continue forward. So now that we've kind of discussed the various types of cardiomyopathies, we've discussed the normal changes that occur during a routine pregnancy. Now to kind of lead into the more pregnancy-induced cardiomyopathy changes, specifically revolving around peripartum cardiomyopathies. And so first we kind of need to understand what is a peripartum cardiomyopathy defined as. And so as we can see here, it's defined as or diagnosed with a left ventricular systolic dysfunction that has an ejection fraction less than 45%. Now this is due to the anatomical changes of the left ventricle, which kind of becomes ballooned and eventually resembles the shape of the sphere. So if we're kind of relating it to another cardiomyopathy that we're more familiar with, we can kind of see it taking the shape of a more dilated cardiomyopathy. So when speaking to the anatomical and physiological changes now that occur in peripartum cardiomyopathies, we're going to see that due to the heart's weakened alterations, we're going to notice some hemodynamic changes, such as we have a reduced filling pressure, we're going to have a decreased stroke volume, and overall a decreased cardiac output that are going to occur. When the heart isn't functioning normally, the body is going to kind of step up in other ways and kind of alter some other physiological processes in order to compensate for the heart's lacking ability. And so the way the body does this in peripartum cardiomyopathies is we're going to see it in the blood vessels, and they're going to increase their resistance, which then leads to a rise in our venous pressure and our overall circulation of blood volume. As that's occurring, we're also going to notice a simultaneous increase in both preload and afterload, and then that additionally kind of plays into the peripartum cardiomyopathy by placing more stress on that ventricular wall. So now, kind of understanding what's going on in those peripartum cardiomyopathies, we can kind of take a look at how those patients are going to present clinically, and then this is kind of going to gear into how this relates in the field of paramedicine. So women that have peripartum cardiomyopathies are going to typically show signs and symptoms that are extremely similar to those in heart failure. So as a paramedic, upon completion of your primary assessment and kind of assessing or gathering your vital signs, you're going to see things like the patient is going to be extremely fatigued. They may have orthopnea, as well as some paroxysmal nocturnal dyspnea. You may note some peripheral edema, as well as some chest tightness. More specific to your primary assessment, you may note the patient to be tachycardic as well as tachypnic. And with some later signs and symptoms, or noticing that the patient is deteriorating a little bit more, you may also note some JVD, and when you auscultate, you may also see or hear some pulmonary rales. When talking about the most extreme cases of peripartum cardiomyopathies and these kind of the clinical presentation of these patients, these women may present with lethal cardiac complications that are going to show as a thromboembolism. They may have various different arrhythmias, as well as they may be showing signs of cardiogenic shock. So now, when understanding the treatment and the management of these patients, women that are presenting with peripartum cardiomyopathies that are stable, that may only be showing that they're tachycardic and tachypnic, but otherwise stable, these women are typically placed on standardized drug treatment plans. And so this is something to watch out for as a paramedic when you are obtaining the list of their medical history, and the medications that they may be on. Some things to look for with these patients is they're going to typically be placed on a loop diuretic. That's going to be usually the first line of treatment, and that's kind of to control that excess fluid buildup. And then if the patient is experiencing some dyspnea or some tachypnea, they may be placed on supplemental oxygen to kind of manage that. So when these patients have their checkups or their follow-ups with their obstetricians or their gynecologists, women that are presenting hemodynamically unstable, drugs that will be often favored in order to treat these patients are your vasodilators. So they'll typically be placed on your nitrates and hydralazines. And then also, considering fetal health and their development, we may also see things like beta blockers that are placed or prescribed for these patients. And so those are kind of the main medications that we'll take note of. One thing you do want to note is that if the women may be presenting with signs and symptoms of peripartum cardiomyopathies, it's important to note that these patients shouldn't be placed on things like your ACE inhibitors, your angiotensin receptor blockers or your ARBs, as well as your angiotensin receptor neprilysin inhibitors or your ARNRIs. And so the reason they're not placed on these things is because they have a high degree of fetal toxicity, and eventually it's going to put both the fetus and the mother at risk. When talking about patients that are severely unstable, so these might be the patients that we end up going to see, they may present with cardiogenic shock or the lethal arrhythmias. And so our care is going to be directed more at managing their ABCs. When we do get them to the hospital, this may look like assisting their ventilations through intubation, as well as treating with inotropic medications or even a surgical implantation of a medical circulatory device, and this may include things like an LVAD. So now kind of transitioning from those anatomical and physiological changes or the signs and symptoms, as well as the management and treatment of these patients, I think it's good to have an understanding about the genetic risks and the potential outcomes for these patients. So some studies have shown that those who develop peripartum cardiomyopathies typically have a history of familial cardiac disease, that being angina, valvular heart disease, or previous cardiomyopathies. It's kind of something that runs in their family history. And so when looking at the genome or the genetics of these patients, they have presented with genetic mutations related to those peripartum cardiomyopathies. However, there hasn't been as much research as there needs to be to kind of fully determine the potential outcomes for these patients, and if there is any correlation between the genetic risks and outcomes. However, one thing that was pretty prominent when doing research on this topic was that the ethnic or racial makeup affects the development of peripartum cardiomyopathies and can in turn affect the potential outcome. So one study that I came across in particular mentioned that Black women are more prone to develop peripartum cardiomyopathies than white women. Additionally, those of African descent have also had one of the highest mortality rates, second to those in the Middle East. However, when looking at the mortality rate overall worldwide, it's pretty low, sitting at around a 6% chance of mortality within a time frame of 6 months after the diagnosis. However, again, looking worldwide, the chances of recovery once the baby has been delivered or the fetus has been delivered is pretty high. So countries like USA, Germany, and Japan are going to have a greater chance of fully recovering from peripartum cardiomyopathies. I think in the study it showed around a 60 to a 65% chance of fully recovering, whereas those in Nigeria, South Africa, and Pakistan, so those Middle Eastern African countries, are going to have a much lower chance of fully recovering. And I think, if I'm not mistaken, theirs sat around a 25 to 30% chance of recovering after delivering the fetus. So that concludes my presentation. I hope you all enjoyed, as we were able to kind of understand more about cardiomyopathies and kind of understand more about the changes through normal pregnancy and then how that's affected through peripartum cardiomyopathies, and then gearing that towards what are some of the management and treatment options, as well as clinical presentation of these patients with peripartum cardiomyopathies.